That was a very nice talk, Sujata, for illuminating us on various how to manage. I think it's important that you identify the small people right in the beginning of the surgery and probably use the iris expanders right in the beginning of the surgery, especially when you are dealing with a patient with IFIS, because you don't want the pupil to come down on you, especially when you have a hard cataract and it's going to make your life more difficult. So what I'm going to talk to you in the next maybe 12-15 minutes is flax in hot cataracts, FEMTO laser assisted cataract surgery in rock hard cataracts. These are my financial interests. As you know, the flax is a fantastic platform. It is a very good platform for complex situations. Of course, for regular, the run-of-the-mill, what you call the walk in the park cases also, the flax I'm using that because the safety factor is much better. And especially in white cataracts, hard brown cataracts, posterior polar cataracts, subluxated cataracts, Fuchs endothelial dystrophy, NHNT means neither here nor there cataracts, in between cataracts. It's very difficult to chop these cataracts, very difficult to crack these cataracts. I'm going to show you a couple of videos as well. Shallow AC, all these are things. Why flax has become very popular? Because, you know, artificial intelligence is becoming popular. In case of diabetic retinopathy, glaucoma, screening. Can a computer perform better than a human brain? Yes, because what I tell my patients is that my hands are good. My hands are 100% safe. But if you want 150% safety in your case, especially when you have a hard brown cataract or a pseudo exfoliation or something, or a subluxated cataract, posterior polar cataract, you want that 150% safety, then probably go in for the flax, and these are the different platforms which are available. I'm using the catalyst which is made by the JMJ, and I always compare the manual phaco and the flax with Sachin and Dhoni. So Sachin is, you know, he's a very good player. Okay, you can't undermine the efforts of what Sachin has done. So manual phaco is very good, fantastic, especially when you have good surgeons like Haripriya and Sujata and so many, Ritu, so many people are here. We're all very good. But Sachin is good only in one format of the game. Okay, he's not a versatile player like Dhoni. Dhoni is good in all formats. So that's the reason why I always compare. The versatility of this flax is something which is really, you have to see to believe it. It's a really incredible technology which is there. So let's see what are the merits. You can have the incision, main side port, the LRI if you want, because even for -1, 1.25, I don't use a toric lens. I put the astigmatic keratotomy of the LRI, which is there in the perfect rhexis, nucleus liquefaction, the pre-chop. Somebody was asking about the pre-chop, which is there already. So white cataract, brown, black cataract, subluxated PPC, all these. So what are the problems with the hard brown cataract? That is the main objective of this course. It's always a challenge to the phaco surgeons, difficult to crack the nucleus because of the leathery attachments of the posterior nucleoplate. The posterior nucleoplate is so difficult. You can see all these chopping techniques, what Haripriya and Sujata were showing, that it's so difficult to chop or separate the leathery fibers of the posterior. Unless you separate them, okay, you can't bring this nucleus into the anterior chamber, because otherwise you'll have white cornea the next day. So thin posterior capsule, large nucleus, there's absolutely no cortical cushion. That's the reason why the horizontal chop doesn't work. For horizontal chopping, you need to go underneath the rhexis margin, and that's the reason why you need to have a good cortical cushion if you want a horizontal chop to be done. So always we do the vertical chop with the sharp chopper, increase in the corneal edema and posterior corneal decompensation, increase in the PCR, nucleus drop, all these problems. Always combine the technology and technique. The technology available in the phaco machines, I think any phaco machine you can put the money now, Indian machines or foreign machines or whatever it is, whether it's Stellaris or Centurion or Signature Pro, whatever, even the Apasonic machines are very good. So these are the brown cataract. You can see here it's like a piece of granite inside the eye, okay? And if you it's such a huge cataract, the entire cataract is completely by the nucleus. The nucleus is more nucleus. Nucleus is as big as the size of the cataract itself. It's almost about 8 to 10 millimeters. And more importantly, the thickness of this lens is about 5 to 6 mm thickness. So that is the reason why I think it's so difficult to operate on these cataracts. If you do a conventional phaco or anything like that, without any cold phaco technology, if you don't use the technique properly, you can end up in a corneal edema. And also the corneal edema doesn't stop the corneal edema. It may clear up in about a couple of weeks or about 1 or 2 months. But you can have a something like a TAS, because the corneal edema releases a lot of prostaglandins inside the eye, inflammatory cytokines inside the eye. You can have something like a fibrin reaction. And even 25% of these cases of corneal edema can have a problem in the posterior segment as well. That is a cystoid macular edema. This is just to show you the comparison between a post-operative manual phaco, corneal edema, or a femto phaco, wherein you can see the day one, the clear corneas. Why it's clear? Because you can see here, I'm just showing you one case wherein there's a grade 3 to 4 cataract. You can see the rexus is already done. Whatever size of the rexus you want, whether it is 5.1, 5, 5.2, 5.3, little. So already it's a pre-chopped. We can make it six quadrants or 8 quadrants. I normally make it 8 quadrants. You can see here I'm chopping, but more importantly I'm using a very straight or almost a blunt instrument like a Sinskey hook, which is not very long also, and the Sinskey hook which is normally used to dial the lenses. I'm just using that because already it's pre-chopped. You can see that I just have to go in, bury. I don't have to use much phaco power at all, and all the way the chop is gone there. The very fact that you get the gas bubbles from there, it means that the posterior nuclear plate is opened up very nicely. You can see that how beautifully all the pieces are already there. It's all the pre-chop technique which has been described by earlier Akashi. It is done by the problem with the pre-chop. What Akashi does is with the instrument, whereas here it is done with the laser. So you can see another patient with a grade 4, grade 5 cataract, and you can see I'm doing the incision. The incision is a true triplanar incision, which is there, the main port as well as the side port. The rexus is already there, and the rexus is about 5.2 millimeters. Make it slightly larger because I want that space in the posterior chamber for me to chop these cataracts. You can see here I do a gentle hydrodissection. It will be a very gentle because already the pneumodissection is already there, and these cataracts are quite hard as well, very big, very thick. You can see here I'm just using my sharp chopper, but the sharp chopper is not doing much force at all. I'm just opening up the cleavage planes which are already there, and the gas bubbles are getting released. Why the gas bubbles are released? The gas bubbles are going all the way, it's cutting all the way to the posterior nuclear plate, and that is the reason why you are getting all these problems. The advantages of the, as you can see, I'm just separating these 8 pieces or the octants, and I'm using very less phaco power, and that's the reason. And then it's really a cakewalk for you. So now and then I inject viscoat. This is something which Sujata also mentioned, viscoat into the anterior chamber, because I don't want, you can use, I'm using in this case a Stellaris machine. Whatever machine you're comfortable, whether it's a peristaltic, Venturi, all doesn't matter at all. So you just have to combine the technology with the technique, and you can see you're going around with this thing. The effective phaco time was only 13 seconds. If you had done a manual one, it would have been about around almost a minute. You can see here, this is a brown cataract. You can see here again, increase, it's almost grade 5, grade 6 cataract. When I presented this in the ACRS, Howard Fine once told, it is in the US, it is called grade 13, these cataracts. So this is something which is, they don't see that these types of cataracts at all there. It's all Californian cataracts, grade 1, grade 2. So something which is, so you can see here how beautifully the cleavage planes are opening up, and it's going all the way, and the catalyst is probably the best machine in this, very powerful, and especially for hard cataracts, and because the Lensex is not as powerful as the catalyst. I don't have any financial literacy, but it's really fantastic. You can see here, you just have to stay in the center, and you stay in automatically the pieces will come to you, and because the pre-chop is being done, and in a Venturi system, there's all these machines are higher-end machines. The stability of the chamber is very good. Of course, as Haripriya was rightly mentioning, you can even you can see this is a femto brown black cataract. You can see it's a grade 6 cataract. You can't see the red glow. It's very difficult to do even a rexus in these patients. And I've done the rexus already. The pre-chop is done, and going ahead with the chopping, just burying the tip and going ahead. Very simple opening up. See how it's beautifully opening up. Otherwise, I have to give lot of lateral rectus forces. I have to give lot of phaco power every time you bury and You have to hold and hold the right piece. In this case, you don't have to. Just have to go in and just open it up. Open it already pre-chopped. Just open it up, and the rest is it's all. It's a child's play for anybody. Just because if I can do it, I'm sure everybody can do it. It's not a very big issue. So this is possible because of the technology which is available to you, which is, I think, it's going to become very popular, this flax, because once they reduce these, you can see this is a black cataract. I'm doing a manual phaco, just to show you the comparison. I'm doing a manual phaco, I'm doing a trench, and then I'm going ahead and using my sharp chopper, which is about 2 millimeter for back cataracts. I have the MOHAN RAJAN chopper, which is made by Appaswamy. I have 1.5, 1.75, 2 millimeter. The 2 millimeter chopper, if you want to stab somebody in the abdomen, you can use this 2 millimeter chopper as well. It's so scary to see under the, but these cataracts, you'll not have any, don't have any fear of penetrating this posterior capsule at all, because as I told you, these cataracts are very thick, 5 millimeter thickness, 5 to 6 millimeter thickness. You can see here, so much of time is being taken to actually chop these cataracts. Maybe it's a good idea to do even SICS, many people can do that, but I do only phaco in these patients because I feel the stability, especially these patients come for a premium IOLs. You can see how much time it's taking, but still it's possible. You can see this thing is EPT is almost 1 minute time. You can see again, just to show you a black cataract with a FEMTO. FEMTO is only about 1/4 of the time which is taken. Again, rexus is done, the pre-chop octants is done, that is 8 quadrants are done. Then I'm going chopping straight away. Carefully, you have to rotate this cataracts, this nucleus. You can see how beautifully it's opening up. Okay, just have to stay there and open up the cleavage plane. You can use any instrument, even a blunt instrument. I'm just showing that because I'm used to these choppers regularly. So that is the reason why I'm just wanted to show you. And you can get consistently clear corneas. You can see the clear cornea in all these are patients on day 1, day 2 of patients who got all brown black cataracts. They come out with consistently clear corneas in all these patients. You can see a pristine wound as well. There's absolutely no wound burn. If you see them on the day 2, day 1 or day 2, you know which eye is got operated. Again, just to show you another patient with a brown cataract. Again, fuchs endothelial probably is one of the best indications for flax. You can see this is a patient with a very dense cataract and a fuchs endothelial dystrophy. The patient required a toric lens as well. I'm using a Callisto system there, and you can see here how because it already does the rexus, it already does the nucleus division. It makes the life easy for you. And you can see here, I just doing a small this thing and then going ahead, very less phaco power. I mean, removing the entire cataract, and you can see that it's very easy. And despite the fact the patient had very low endothelial count, you can see the 2 hours post-operatively and the day 2, how the cornea is crystal clear, and subsequently after a week also. Just to show you the small pupil. My small pupil, if it's very small pupil, you can obviously do femtocataract, but it's a little larger than about 5.7 or 8 millimeter, because I need to get a rexus of about 4.7 millimeter. So the pupil, the rexus will always be smaller than the 1 millimeter smaller than the size of the pupil, which you can adjust in catalyst mission. So that is, I think, one of the biggest advantages to have this small pupil. We have a small pupil, because the nucleus, the catalyst mission cuts beyond the margin of the rexus also. So you have a small pupil and you have a good rexus also, which is there, and pre-cut cataract, which makes your life very easy. So reduce surgical time, reduce effective phaco time, more precision, clearer corneas day 1, reduce complications as well. Just to show you hard brown cataract with sublex, I'm sure Nivian will correct. Just to show this, a patient had a shuttlecock injury 20 years back, you can see here, and this shuttlecock injury had a subluxated total white cataract. Okay, if you're going to do this cataract on a regular basis, it's going to be so difficult for you to even do the rexus, because for the rexus you need support. Okay, from the peripheral resistance has to come. But if you did a femto, you can see here the rexus is already there. I just make the incision there, and then I pull out most of the times, 99.5% of the time, it's a free-floating rexis. You can see here, I'm just putting the side port and supporting that area with the iris hooks there. I know capsular hooks are always better, but this just the localized zonal dialysis which is there. And you can see here, already it's pre-cut. Okay, so I have to go in and just pick up the cataracts. You can see I'm picking up the cataracts very easily. Again, separation is there. I just have to go in and separate, and you can see here how I'm doing it very, very without any problem at all. And then going ahead with the, yeah. So life becomes very easy in this particular patient had traumatic mydriasis. So I put a MA60 lens, a multi-piece lens in the sulcus, and captured that in the bag, and then went ahead with the single pass 4-throw pupilloplasty as well. So just to show you this, again, we are talking about white cataracts, Argentina flag sign, okay? The Argentina flag sign is a type 1 cataract where the interlenticular pressure is very high. It's not only an interlenticular pressure, it is also the pressure from the vitreous cavity as well, the positive vitreous pressure. There are 4 components. One, the pressure underneath the anterior capsule. The nucleus is bulky, and there pressure in front of the posterior capsule, which pushes the nucleus as soon as you make a nick in the anterior capsule. So this Argentina flag sign can be prevented if you have a Zepto, but the problem is Zepto is an invasive technique, and but it works very well. Or you can do, this is what Sujata was talking about, you can just do a needle aspiration of the front component. It takes care of the anterior, that is the first component which is there. You can just do and then go ahead with the rexis, which is possible. It works about 50-60% of the time. Or you can use a puncho-rexis, which works in my hands. It works about 100% of the time. But more important than the puncho-rexis is the FEMTO cataract. If you have access to FEMTO, even the patients cannot pay, go for this, because you can get a very good, you don't have to do a double rexis, you can just have the size of the rexis, 5 point. If you have a bigger hard cataract, white cataract, and if you have a bigger rexis, it makes your life very easy because you have the more space in the posterior chamber to remove these cataracts. You can see here, only thing is to look for skip areas when you do this thing. Many times it may not be a free-floating rexis. There can be small areas which can be attached, so don't try to pull it out. So take-home message, Flax is fantastic technology. The cost is going to come down, and definitely it's going to be user-friendly, and more people will start using it in the future. White cataracts, hard brown cataracts, posterior polar cataracts, subluxated, fuchs endothelial, and the in-between cataracts also. Safety, precision, bladeless, consistency, wow effect, good platform for marketing, differentiation practice. Thank you again, Sujata. Thank you, the Chairman Scientific Committee and the Scientific Committee of AIOS for the wonderful opportunity.
Thank you, Dr. Mohan. We have the last speaker waiting, Dr. Nivian. And yeah, please.
Yeah.
Where you don't have flags, so any experience with MyLoop or with mechanical
Pre-chopping.
Yeah.
We're just discussing it the previous talk after.
MyLoop can,
MyLoop is, it needs, I think, a learning curve. Because I've seen quite a lot of good demonstrations, but don't have a personal experience in it.
Now, MyLoop is good. Only thing is, MyLoop has got a learning curve. The problem is MyLoop is that you need to have a good rexis, that's fine. But you have to make sure, because these don't have any cortical cushions. So you need to make sure that you are on the correct plane. And then we have seen the worst complications with MyLoop. Not with us, but with referred from other people. But it's it's one of the good promising technologies. Yeah. But I would suggest that if you don't have flax, yes, manual phaco, the way I showed the vertical chop technique, use the sharp chopper, because if you're going to use the vertical chopping technique, use the sharp chopper. If you're going to use the horizontal chopping, don't use sharp chopper, use a blunt chopper. Okay? And sharp chopper, Mohan Rajan chopper, if you want, I can send it across to you.